All right, perfect. Okay, so before I start, first of all, I'd like to welcome you back, right? And I'm fairly confident that today's lecture is going to be very beneficial for everybody. Like usual, what I'm going to do is, even though the PowerPoints and the slides are there, what I'm going to concentrate on is making you guys understand the concepts, okay? To just give you a little bit of introduction, because some of you may not know who I am. My name is Jamil Ferra. I'm a maternal fetal medicine specialist, all right? And I also specialize in learning. There is nothing more in the world that gives me more joy than teaching people. So I'm very happy to be here, and I hope you guys are also happy and eager to learn. Alloimmunization, I can tell you, is a topic that a lot of people find challenging. Is it an antigen? Is it an antibody? What's KEL antibody? So a lot of people find it confusing. So what I'm going to do is stick to basics, and like what we did in the previous lectures, we are going to make sure that we make it easy and understandable, right? Since this is an international audience, and I know some of you from different parts of the world, what we are going to be presenting here today is consistent with the American College of Obstetrics and Gynecology guidelines and the Society of Maternal Fetal Medicine. So again, the goal is clear. It is fun learning, okay? It is fun learning that minimizes memorization, all right? Fun learning that minimizes memorization. And that's what I have found in years. Things that actually you understand the concepts of stick in your head. Things that you're memorizing constantly go away very quickly. So I can see all of you. I know that you're all very, very confused before the lecture because alloimmunization is not a cool topic, but you won't look like this when we finish. So when somebody comes in for their first prenatal visit, right? What do we normally do? We do a whole bunch of labs, and that also includes what? It also includes type and screen and antibodies. Now you've got multiple things that may happen here. The patient may be Rh positive or maybe Rh negative. She may be A, B, O, right? So the two things that we look for are patient's blood type, and is she Rh positive, negative, and does she have an antibody? Is this clear for everybody? Is everybody clear and listening to everything? Because I think if you guys understand, so there is a very, very big difference between somebody having a blood type of, let's say, O negative and having no antibodies to it. And then there is a big, big difference if somebody is O negative, antibody positive, right? Is that, and then these are all key to understanding. The other thing that I want to also allude to and talk about is, in an ideal world, can you have both an antigen and an antibody for the same thing in the same person? In an ideal world, no. Correct? Absolutely not. So if the mother has an antibody, could she have the antigen? No. And these are concepts that make things very clear. You can only have either the antigen or the antibody. Perfect. And then when we talk about alloimmunization, see how I'm going to build bricks slowly, little by little? There are two things. There's prevention of alloimmunization, and then after that, if antibodies have formed, you are no longer in the prevention mode. See the difference? Now, there is only one type of antibody that you can prevent. Which antibody is that? Absolutely, the anti-D. That's the only antibody you can prevent. The other antibodies, you can't prevent them. You deal with them when they happen. Now, how do you historically prevent anti-D from happening? What do you give those people? What should you give them? Rhogam. Okay, now, if an antibody has formed, can you give Rhogam? And that's where a lot of you make that confusion. So let me give you an analogy. If somebody is getting the hepatitis vaccination at birth, right? Your whole purpose is to prevent hepatitis from happening. If a patient already has hepatitis, is there any benefit from giving the vaccination? The answer is absolutely not. So that's why, and this is an area of confusion, and I'm going to keep hammering that because a lot of you confuse that. In the presence of an anti-D antibody, you cannot give Rhogam because it's not going to prevent anything. Keep that hepatitis and in your mind. I give the vaccine to prevent the hepatitis. Once hepatitis happens, I don't give the vaccine. Once I have anti-D antibodies, there's no point in giving Rhogam. And there are specific prerequisites to giving Rhogam, and that is mom has to be Rh negative, and she has to have no D antibody present. Okay, that's the prevention arm. Now, when we move to the fetal assessment, risk and management of complications, those are people that already have the antibodies. Now, these antibodies, do they have to be anti-D antibodies? No, right? Now, when an antibody has occurred, the management is going to be the same, irrespective of the antibodies, with a few exceptions because some antibodies are not dangerous, but the concept is the same. All right? See how we're building a picture? This is what I want you to think. Am I preventing something, or am I assessing if the baby is at risk and then managing the complications? The only thing I can prevent is D antibodies from forming. Other than that, I can't. And once the antibodies have formed, there is absolutely no role for Rhogam. This is concept number one. Concept number two is this. When the body is exposed to an antigen, what is the response that the body forms? What is the response that the body forms? So if the mother is exposed to an antigen, it is going to form an immune response. Now think of it that way. What immune response usually happens early? It is usually IgM. Now, this is where the understanding is important. Is IgM big or small? Could it potentially cross the placenta? No. Now, move forward, and the mother is exposed to the same antigen again. The body is going to form an immune response again. This time, it's a much more mature immune response, much more specific, and that is usually IgG. Is IgG small or big? Could it potentially cross the placenta? Aha, now we're building the story. See? And we're going to continue building on this story. Now, let's look at this slide. This is what I call the prerequisite problem slide. And what I'm going to do, if you guys remember the twins lecture, and those of you that didn't attend, it's okay. Although you missed out on a whole bunch of great things. But anyhow, all right, what I'm going to do is I'm going to start with this diagram, and then I'm going to build on it. So that by the time we are done, I'm going to give you a summary that is all going to be in this diagram. Is that cool? So these are the prerequisites for the problem to happen. The mother cannot, didn't we say the body cannot have both antigen and antibodies? Correct? So the mother cannot have the RH, the mother cannot have the RH antigen or any other antigen if she has the antibody, right? Sounds good? And then that antigen has to come from somewhere. If the mother doesn't have it, who's going to provide the antigen? The baby, but where's the baby going to get it from? The father, absolutely. Okay, so here is concept number 2. If the father of the baby doesn't have the antigen, could the baby have the antigen? Yes, I know, Hala, what you're thinking, provided that paternity is not in question. Now, somebody said that it's a little bit confusing, okay? So let's go back to basics, right? In a human body, you can't get both the antigen and an antibody, correct? You can't. You can't, because antigen and antibodies fight. Agreed? Omar, I'm going to concentrate on you. Antigen, antibodies will fight. So each body can either have an antigen or an antibody. So if we already did a blood test and the mother has an antibody, she can't have the antigen. And no problem will happen unless we expose that mother to the antigen. Is it clear now, Omar? So the antigen has to come from somewhere. If the mother doesn't have it, for the baby to have it, it needs to come from the father. And yes, Hala, I paid attention to your question, provided that paternity is not in question. If the father does not have the antigen, then we know that the baby will not have it. All right? Then, number 2, father of the baby has the antigen, it has to pass it to the baby. See? Now the baby has it. Does that mean the baby has to be harmed? Not necessarily. First of all, that antibody has to be harmful. 2, it has to be of a high quantity. 3, it has to cross the placenta. See how we're building a nice, wonderful story, right? This table or this diagram is going to help us moving forward. Before I move from this diagram, is this diagram clear to everybody? Is everybody understanding how this diagram works? All right, perfect. It is not going to be confusing when we finish because we're going to go through this multiple times till we'll go through it, Sarah. Okay, don't worry. We'll go through it multiple times and you'll understand it. Okay, so let's talk about the incidence of Rh negative and think of it that way. About 15% of Caucasians are Rh negative. 8% of African Americans are Rh negative, and about 1 to 2% of Asians are Rh negative, which means an Rh negative mother has about an 85% chance of marrying an Rh positive person and more. See, hence the problem, correct? Now, here's another area that I find a lot of you find confusing. When we talk about antigens, right, usually the genes are in 2 copies, which means any antigen that the father of the baby has either has 2 copies that are the same, and that is known as homozygous, or they have copies that are not similar, and that is known as heterozygous. Yes, absolutely, alleles, right? So if a father of the baby has the antigen and is homozygous, it is going to 100% pass that to the baby. See? Right? See how this is now building nicely? Okay. So we talked about prevention. This can only prevent Rh negative mothers from getting the D antibody. And we talked about giving the immunoglobulin. And we said there is no benefit of giving it if the mother already has the antibody. Now, here's a very nice, interesting way. Does anybody know how the immunoglobulin works? Or and then that's another way of understanding. Why do we give the immunoglobulin? What is beneficial? So think of it that way. If I hide something from the immune system, right? Is the immune system going to form the antibodies? No, because it's not going to know it's there. So think of the immunoglobulin as a sponge. You give that, and that's why timing is essential, and that's why we give it as close to birth as we can, because it's going to act as a sponge. And what is it going to do? It is going to trick the immune system and not form the antibodies, right? See, so that's what you do. You give a sponge. The sponge absorbs all of the antigens. Let's build on this story. Hence, if you expect that there was way more antigens, shouldn't you give more Rhogam? You need more sponges, all right? If you have a big spill in the house and you've got one little tiny napkin, can't fix it. You need multiple napkins, right? So you need more mops, more sponges, right? Beautiful. We are building a beautiful story, okay? Which is why before you give the immunoglobulins, you need to check and make sure that the mom does not have the antibodies. All right. When do we give the immunoglobulin? We said Rh negative mom, right? And anti-D negative, right? Or D antibodies negative. So we give it routinely at 28 weeks, and we give it routinely 72 hours after the delivery of the baby, provided that the baby is Rh positive, because it doesn't make sense now. We have the baby in front of us. Can't we figure out what the baby's blood type is? We absolutely can. Okay. Now, you check what time to check the antibody of the mother at 28 weeks. That's why you do a type-in screen at 28 weeks, and if it's negative, you give the immunoglobulins. And that's why I'm saying there is a lot of people around the world that give the immunoglobulin at different times. I'm specifically sticking to what we do in the United States, all right? And then we give it also after first trimester pregnancy losses. We give it after invasive procedures. Do you see the common theme? We give it anytime there is a potential for the baby's cells to cross into the maternal circulation. So if I put a needle through the mom's belly, wouldn't that have an increased risk of potentially, making the maternal fetal circulation cross together? Absolutely. You have a miscarriage. That can happen. Birth is the most common one of these times. All right. Are you guys happy with how this is going? Those of you that are drinking coffee, I am very jealous. Because there is studies that show that fetal red blood cells occur as early as 38 days. So that's why. As long as you give it within a timely fashion, you are fine. So the question was, when do you give Rhogam? As long as you give it soon after your procedure, and we're coming to that. These are the strongest types of recommendations, right? These are still recommended, but they don't have as strong of an evidence as the ones that we talked about. But most people will say, well, immunoglobulin is not harmful. Getting anti-D is extremely harmful. So why don't we go ahead and give it? So I think that's very reasonable. If you have abdominal trauma, external cephalic virgin, right? Threatened abortion or induced abortion, and also in molar pregnancies, which is interesting. But that is one of the recommendations. So what happens when we don't prevent the alloimmunization? What happens when we don't prevent the immunization? A, we may have not given the Rhogam in a timely fashion, right? Or there may have been more bleeding than what we had anticipated, and the Rhogam that we gave was not enough. We skipped giving the Rhogam at 28 weeks. But more importantly, even if we do everything right and we give as many Rhogams as we need to, there are still people that will develop alloimmunization despite and irrespective of what we do, right? And that is 0.1 to 0.2%. Okay, so let's look at the math here. If we give nothing, we give absolutely no Rhogam, an Rh negative mother that has an Rh positive fetus, there is a 17% chance of sensitization without treatment. So before we had Rhogam, about 9 to 10% of pregnancies had the D antibodies and they had the hemolytic disease of the newborn. That's a high number, okay? So we said the most risky time is at time of birth. So 90% of cases of alloimmunization occur at the time of the delivery. And most alloimmunizations, most alloimmunizations are a result of fetal maternal hemorrhage of less than 0.1 ml. That is not a high number at all. All right. So look at this number here. If we give Rhogam postpartum, we reduce that 17% to 2%. And then if we also give Rhogam at 28 to 29%, we go from 17% to 0.1. Do the math. Postpartum administration reduces it by 90%. Roughly 90% of 17% is 2%. And then giving it again at 28 to 29 weeks reduces it by 0.1%. All right, I want to do a little bit of a check here. Okay, is everybody awake? Is everybody awake? All right, because this here is, for anybody that takes an exam, this is an exam favorite. It doesn't matter whether you're in preschool or you're in fellowship, all right? This here is an important slide that people just love to ask. And the information that we're gonna give from this slide is extremely high. So if they tell you, is there a way of knowing whether fetal cells went into the maternal circulation, what should your answer be? Is there a way of knowing that fetal cells have crossed into the maternal circulation? Yes, the Kleihauer-Bethke test, or there is another test. Can anybody think of the name of the other test that can tell me if fetal cells went? Yeah, the AP test, all right, or otherwise known as the Rosette test. Wonderful, excellent. Now, we're going to talk about the differences between the KB stain and the AP test in a minute, right? But man, those of you that are studying for any exam, it doesn't matter what it is. We've just given you so many brownie points in this lecture. So the Kleihauer-Bethke test is quantitative. What does that mean? It can tell me the percentage of red blood cells that have crossed into circulation. So it can tell me the amount. Remember what I said? If our mop is not, I like the mop or sponge is not big enough, we need a bigger sponge. This is going to help me determine how much immunoglobulin I'm going to give. Now, does anybody know how the KB stain works? It's actually a cool way. Does anybody know? Does anybody know how the KB stain works? Yeah, absolutely. So it relies on two properties. That hemoglobin F is more resistant to acid than maternal hemoglobin. So when we do the acid elucidation test, the only cells that we will see will be fetal cells. Hence, there is a problem. You know what that problem is? If the mother already has a lot of hemoglobin F cells, we may get a false positive. So in cases of sickle cell, could that falsely give us a positive KB screen? Absolutely. Yep, there you go. All right, sounds good. I feel that you guys are enjoying the lecture. I'm definitely enjoying your contributions. I feel that people are really giving us a lot of feedback. Okay, absolutely. So hemoglobin F is resistant to acid elution. So what do we see? Only the fetal cells remain. Okay. The apt or Rosette test. The difference between it and the Kleihauer-Bethke test is one of them tells me how much, the other one tells me yes, no. And that is similar to the pregnancy test. The beta HCG in the blood tells me how much, the urine tells me yes or no. That's another way of remembering it and knowing it. Okay? So this is really not a very useful test in the clinical aspect. You know where this is very useful? In an exam setting. They just love to bring it in the exam, right? For us, if I picked up the phone and called our lab and said, hey, I want a Rosette test, you're going to get something similar to, what? What do you want? It's not done clinically. The KB stain is much more superior, okay? All right. So here is another slide that I want you guys to pay attention to. How much Rhogam covers how many cells? And there are tricks to this. And that's why I put this in red. 3 mcgs of Rhogam cover 30 ml of blood. There's supposed to be an L here, and 15 mLs of fetal red blood cells. So pay attention to how the question is worded. If they ask you how much Rhogam you give, and they give you whole blood, then 1 ampoule covers 30 ml. If they give you fetal cells, then it is 15. Okay? Now, I know this is a topic that causes a lot of you some problems, so I even put how you calculate it. Now, if any of you have seen a KB stain or a KB result, it comes back in percentages, right? Okay? So it comes back in percentages of red blood cells. And if you assume that that percentage, 1%, 2%, 3%, whatever percent you want, you assume that the maternal blood volume is about 5 liters, the way you calculate the number of mLs is percentage times 50. That will give you the number of mLs. And then we said that the 1 vial covers 30 mLs, so you divide it by 30 to give you the number of vials that you need to give. Now remember, this is the number of extra vials you need to give. So you give your first dose of Rhogam, and this tells you how many more you need to give. Okay? All right. Before we move on, is this slide clear? I want to see all of you tell me it's clear. Or those of you tell me it's not. Okay, so I get somebody that says no. Okay, so let's go back real quick. If we have cells that cross into the maternal circulation, the way that we calculate how much Rhogam depends on what information they give me. If they give me the mLs of whole blood, then 1 Rhogam is 1 ampoule. Oh, well, the KB stain, you should do it anytime you suspect that there's fetal cells that crossed into the circulation and you think that they're excessive. So a lot of people will do this during the time of birth, okay? When they feel that there is excessive fetal maternal hemorrhage, all that sort of stuff. A lot of people will also do that after accidents, trauma, because that's going to tell me whether that trauma caused a lot of fetal cells to go in, right? Now, some people will also do it to you know, in non-Rh negative people to see if there were any fetal cells that crossed. Okay? Is it clear so far? So we said the KB stain tells me how many either mLs of whole blood or how many fetal cells went in. And the amount of Rhogam differs based on whether they told me it was 30 mLs of blood or 15 packed RBCs. And if we have more than 30 mLs of blood, then one ampule or vial of Rhogam is not enough. Okay? All right. So what we'll do is, because in interest of time, and I don't want, some of you have understood it, I will not go anywhere at the end of the lecture. So those of you that didn't understand this, I am more than happy to go over this as many times as you want at the end of the lecture. Okay. So now we have assessed how to prevent the D from happening. Now we have somebody that comes in with antibodies. Okay? So the aim of the aim of management is to do what? In anything in pregnancy, what are you trying to avoid? Any pregnant lady, what are you trying to avoid? Same thing here. You are trying to avoid, number 1, early delivery or preterm delivery, and you are trying to prevent maternal and fetal harm. And you are trying to achieve a balance between the two. These, and anything in obstetrics, right? Preeclampsia. When do I deliver? When do I not? Fetal harm, maternal harm, decreasing prematurity as much as possible. The same thing applies to alloimmunization. Okay? So I'm trying to delay delivery as safely as possible. So let's go back to our diagram. So mother has the antibody to that antigen, right? What is the first thing you need to do? If I now have somebody who comes in and they give you the results of their test, and they have an antibody. What's the first thing that you need to do? Before the titer, okay, before the titer, they need to tell us what type of the antibody it is, right? What type of antibody? You guys are right. We're going to find out the titer, but I want you to think first, right? If somebody told me an antibody, then my next step is going to be, what is the antibody? And then remember that antigen antibody thing? Then I am going to say, well, if now somebody has told me the antibody, I want to see if the baby is at risk. So what am I going to do here? I am going to see if the father of the baby has the complementing antigen. So for example, if the antibody is KEL, what antigen am I supposed to look for in the father of the baby? The KEL antigen, right? And so forth. Now remember, you know what is a common mistake that a lot of people do? Is and I've seen that even now, some of the OBs, that's the referrals that they get. They screen the father of the baby for the antibody. Is that helpful? No. The father of the baby should be screened for the antigen. So the first step is to test the father of the baby. And there are two things that may happen. Father of the baby may be negative, and if paternity is not in question, is the baby at risk? If paternity is not in question and the father of the baby does not have the antigen, is the baby at risk? No, right? Now, if the father of the baby, and that's why there's no further testing, if the father of the baby is positive, could the baby potentially be harmed? And the answer is yes, right? And those of you, I've gotten a lot of private messages. Remember, there is, in multiple choice questions, the harmful antibodies, there's a lot of them. And there's a big table that's about 3 or 4 pages in our books. So you don't have to memorize all the harmful and what you, even now when I see an antibody that I don't commonly come across, I go to our reference table and see if it's harmful or not. But there are some that are very common, known to be harmful. And usually, you remember them this way. It's K kills, Duffy dies. That means KEL antibodies and Duffy antibodies are really, really bad antibodies. And then Lewis lives, right? Which means Lewis is usually not a bad antibody. Okay? All right. So if the father of the baby is positive, the father of the baby may be homozygous, and those of you that were paying attention before, if the father of the baby is homozygous, what is the chance, right, that the baby will get it? Homozygous, it's 100%, because it's going to get one of the copies. Excellent. So now, do I need to test the baby? The answer is no, because I know 100% that the baby has the antigen. Now, if the father of the baby is heterozygous, then it is a 50-50 chance. Now, how can I see if the baby has the antigen or not? What can I do to see if the baby has the antigen or not? You can do an amniocentesis. Having said that, right, an amniocentesis is very invasive. And right now, but remember, free fetal cell DNA only looks for baby's blood type. That's all it does. So it doesn't really help me in antibodies, although when you talk to the companies that do the free cell DNA, soon they'll be able to tell us with good reliability that whether the baby is antigen positive or negative. So remember, cell-free DNA only tells me the baby's blood type. Now, what I do in my practice, if the father of the baby is heterozygous and there is antibodies, I offer them an amnio, but I don't push for it, because I think, right, that it is less invasive to do middle cerebral artery than to do an amniocentesis. What is another problem of doing an amniocentesis in these patients? is if they have a lot of antibodies, what may I do inadvertently? What may I do inadvertently? I may take these cells from the maternal circulation and put them into the baby's circulation. Look at that, right? So for me, I usually move on to peak systolic velocities if I need to. However, having said that, we've jumped the gun a little bit. Okay, so then, determination of antigen status. If the father is negative to antigen, no further assessment is needed. Homozygous has, and the only reason I have these slides there is for something simple. When you look at the diagram, this will also help you remember what we covered in the diagram, okay? Now, the next step we said that we need to do is the antibody of the harmful type or not. Now, let's say the antibody is of the harmful type. Then what is the next step? And I saw all of you mention it. What do you do after that? Before the MCA? Before the MCA? The titer, right? And here is a problem that a lot of you face. The titer comes in 1 to 4, 1 to 8, 1 to 16. Which one is a worse titer? A 1 in 4 or a 1 in 64? Which one is a worse titer? Okay, a 1 in 4 or a 1 in 64? It doesn't depend on the antibody, okay? Let me explain to you how the titers work. And that's an area of confusion. 1 to 4 is actually better than 1 to 64. And you know why? Because what 1 to 4 simply means is I diluted it 4 times to get rid of the antibody. That means there wasn't a lot. But if I had to dilute something 64 times before I got rid of the antibody, that means the antibody had a lot of antibodies in it, right? Is it making sense now? So that's why 1 to 4 means I diluted it 4 times and got rid of it, not very high. 1 to 64, I diluted it 64 times. So then I have to see, okay, is my antibody significant or not? Okay, and the significant titer is lab dependent. The significant titer is lab dependent. But most labs use anywhere from 1 to 8 to 1 to 32. You should contact your local hospital lab. I know for our hospital, 1 to 16 is considered critical. Okay, so a critical titer is anywhere between 1 to 8 to 1 to 32. If the critical titer is not met, then what do we need to do? Serial titers every 3 to 4 weeks. There is one exception to this, where titers do not matter. Does anybody know the antibody? Anti-Kel. Anti-Kel or Kel does not follow any rules. Kel does not follow any rules. This is the only one where if you have Kel, you immediately screen for fetal anemia. You don't have to do titers. Here's another area that you guys also confuse. Let's see. Our titers today was 1 to 4. And then 4 weeks later, we do it, and now it's 1 to 64. Is there any benefit to repeating the titers after you cross the critical titer? The answer is no. So your titer is there to make you decide whether you need to screen for fetal anemia or not. Do I need to screen for fetal anemia or not? Okay, so now, antibody crosses the placenta and potentially can cause fetal harm. What modalities do I have that I can use to screen for fetal anemia? MCA Doppler. What else? Amnio, what are you looking for, Hala, in an amnio? What are you looking for? Remember, right? When you get antibodies that attract the antigens, what do they cause? Hemolysis. What is a byproduct of hemolysis? Bilirubin. So in your amnio, you're looking for bilirubin. What's another way of screening for fetal anemia? is to take a blood sample from the baby, correct? True? These are all things that you can do. However, if I tell you that they all have relatively similar sensitivities, would I want to do something invasive or something not invasive? Non-invasive, right? But remember, true or false, a peak systolic velocity that is elevated in the MCA can diagnose fetal anemia. It is not true. It is screenly positive. So every screening test has false positives. Correct? Remember, peak systolic velocity screens for fetal anemia. So when it's positive, you think the baby is anemic, but before you transfuse the baby, what do you measure before you transfuse? If the baby's truly anemic or not. Okay? Sounds good? Remember, every screening test in the world is not diagnostic. Peak systolic velocity is a screening test. All right. So we talked about the peak systolic velocity of the middle cerebral artery, amniocentesis, fetal blood sampling. Now, why is the measurement of the peak systolic velocity good to screen for fetal anemia? Why is it a good way to screen for fetal anemia? A, non-invasive, easily reproducible, right? Easily reproducible and accurate, right? And it's also very sensitive. But why does it, and that's why I want you to understand, why does the peak systolic velocity go up? Why does it go up? Right? It means there is more blood flow going to the brain. So think of it that way, right? If somebody is anemic, what normally happens to their heart rate? It goes up, right? So if the baby is anemic, its heart is compensating. That means there's more velocity going to the brain, and that's why reduced viscosity, I love that, right? And then what happens is now you have more blood flow. And what is our magical number that tells me that the baby is potentially anemic? What is the magical number? 1.5 multiples of the median. Absolutely. And none of you should memorize except this number, because it's usually a table. You put it in the computer and it tells you how many multiples of the median it is, right? It is only started once the critical titers are reached. Now, the exception to that as well, if the mother had a previous alloimmunized pregnancy, then the next pregnancy, you do not have to look for titers because you know this baby is potentially at risk. Okay? Potentially this baby is at risk. Now, here is an interesting question for you. What if a mother got alloimmunization in the first pregnancy? Is that possible? Is it possible for it to happen in the first pregnancy? Yes. Can somebody tell me some of the circumstances? If she had a previous blood transfusion, all right? And what else? IV drug use can actually give you antibodies, needle sharing, okay? And absolutely, if they had an invasive procedure at the end of the beginning of pregnancy or trauma at the beginning of pregnancy, absolutely, okay? Excellent. I'm really happy with how you guys are interacting, right? Do you guys feel confident and have more of an understanding of the topic now as we're moving on? Right? It's making a lot more sense, yes? All right, sounds good. So we talked about this, and here is what I can tell you. It has a 12% false positive rate. And here is the other thing that you guys need to think about as well. The peak systolic velocity also increases with age, with gestational age. So there's actually more false positives after you are more than 34 weeks. Okay, perfect. We talked about the 1.5 MOMs, and we talked about the false positive rates increasing after 35 weeks. Now, we will kind of briefly talk about Lilly's curve and the Queenan curves. And I actually was lucky enough to meet Dr. Queenan, which was one of my highlights of my life. Very smart gentleman, very, very, it was nice meeting him. So the Lilly's curve or the Queenan curves, they look for bilirubin. That's what they do. And then as far as the Lilly curve, it puts it in zones, right? The higher the zones, the worse the anemia. Zone 1 indicates only mild disease. Zone 2 indicates fetal anemia to correspond to about 8 to 13 grams per deciliter. Zone 3, right? What do you want to know about twins? And I've seen that question before, but MCAs for twins, peak systolic velocities don't change. If they're above 1.5, they're still considered abnormal. All right, it's still anemia is anemia and peak systolic. So if I understood your question correctly, peak systolic velocities in twins do not, the standard and the normal does not change. All right. Okay, these are the zones. The Queenan curve, valid as early as 14 weeks. The problem with it is it has a very large indeterminate zone, so not very helpful for us. So, in all honesty, the best test still remains the peak systolic velocity, right? Now, for fetal blood sampling, transfusion is generally recommended if the hematocrit is less than 30%. And once hydrops develops, usually the hematocrit is less than 15%. Now, here's what I want you to decide. If you have a baby that you think is anemic, and concentrate with me here for a minute, what options do I have? I think the baby's anemic. Option number 1 is going to be transfuse. Option number 2 is going to be deliver. So which one will I decide? It depends on the gestational age, right? And the number that I generally want you guys to think of is 34 weeks, generally, okay? A good rule of thumb is we will transfuse all the way up to, and I'm not changing the number, but generally we will transfuse up to 32 weeks, right? Because each transfusion lasts for about 2 weeks, and then deliver anytime after 34 weeks. Does that kind of make sense? And the transfusions usually happen every 2 to 4 weeks. So this is a little bit more detailed than what some of you may want to know, but you know what? It's not difficult information. It is cool information to know. It doesn't matter who you are. This is a very, very nice piece of, so this is more directed towards people that actually do this on a daily basis, but it's very easy. And you know what? If I'm giving it in an easy way, why not know it? So if you are going to transfuse a baby, what are some of the things that will help you determine how much? Yes, you do. You give steroids to induce fetal lung maturity before you transfuse. Absolutely, because you don't know if the procedure is going to be correct or not. So the degree of hemolysis, so how much your hematocrit is, and believe it or not, it also depends on the estimated fetal weight. The less the weight, the less the amount of blood that you need. So there is a calculation that helps you determine how much, it's a calculator. You determine how much your hematocrit that you want to reach to is, and then you have a gestational weight, age, and an estimated fetal weight, and then it tells you how much blood you are supposed to transfuse. Now, this is a nice little interesting piece of information. The expected decline of fetal hemoglobin is about 0.4 grams per deciliter per day after the first transfusion, 0.3 grams per deciliter per day after the second transfusion, and 0.2 grams per deciliter after the third transfusion. So that actually gives you a rough estimate of how quickly you're going to lose your hemoglobin. All right? And then it can be given in multiple sites. Does anybody know where we can give the transfusion? Where can I give a fetal transfusion? What are some of the sites that I have? It can be given in the umbilical artery, umbilical vein, or in the fetal abdomen. And that's what intraperitoneal is. Umbilical artery, umbilical vein, and intraperitoneal. Now, usually when we do the transfusion, getting into the vein is easier because it's bigger. And also, it is less likely to cause vasoconstriction and fetal decelerations. The easiest to get into is the abdomen. The problem is not as beneficial to the baby as going into the vein or artery directly. And yes, we do give paralytic agents, and we're going to talk about them in a minute, okay? The umbilical vein is the preferred vascular access site, and it can correct fetal hydrops in about 24 to 48 hours and spares end organ damage and death. Okay, here is the access site. You look for the free loop if necessary, or you can actually insert it next to the placental insertion site, okay? And then you give a paralytic agent, and this is just an example like acurium, which is 0.4 milligrams per kilogram, and that is given intramuscularly. All right, those of you that I've lost because I have been talking about some stuff that is a little bit on the complex side, I need you guys to come back, because what I'm going to be talking about now is a piece of information that is loved by multiple exams. What type of blood do you transfuse the baby with? Tell me. O negative. CMV negative. Irradiated blood so that it can decrease, and leukocyte poor so that it can prevent or reduce the risk of the graft versus host reaction. And yes, absolutely, Marwa, the blood has to be concentrated, right? It has to be hemoconcentrated blood, absolutely. Okay, with the hematocrit reaching, somewhere above 70%, absolutely. Okay, now survival is 92% if we have not had hydrops develop. So it's a really life-saving tool for the baby. And 70% if hydrops has developed. Now, I know there are some fellows out there. So you have to also remember, right? If I transfuse this baby way too much, what am I going to do? I'm going to overload that fetal circulation. So our goal before 24 weeks should not be to raise the hematocrit by more than 25%. And then after 24 weeks, we can raise it by 40%. And if you have to, you don't give one transfusion and finish. If you think that your starting hematocrit was extremely low, you raise it by 25% and then repeat the procedure in 24 to 48 hours. Is that making sense? Now, some of the complications of fetal blood transfusions is sensorineural hearing loss is more frequent. Yes, the paralytic agent is given to the mother. Okay, so it is strongly influenced by gestational age. Okay, and if you have mild fetal hemolysis, you deliver between 37 to 38 weeks of gestation. Okay, and this is what we talked about. Severe disease requiring transfusion is recommended. You do the fetal transfusion all the way up to 32 weeks, roughly every 2 weeks, till 34 weeks, then after that you deliver. If this happens anytime after 34 weeks, the general consensus is we should go ahead and deliver. Okay, so what is hydrops? What is hydrops? What is hydrops? Hydrops is a fancy way of saying the baby has become edematous, and it is diagnosed if we have 2 or more fetal effusions, whether it's pericardial or ascites, right? And anemia usually happens if the hematocrit is below 15%. And it can be divided into immune and non-immune. And I will not talk about immune and non-immune because my good friend, Dr. Wajih, is going to be talking to you about hydrops and that sort of stuff in his upcoming lecture. Okay? All right, so let's go to our diagram. Okay? This is a summary, just like I had promised you. Okay, now while what you call it, after the last lecture, I actually got some questions about cervical length screening for twins and the type of anastomosis in twins. So when I'm done, don't go away, because those of you that asked the question, what I'm going to do is I'm going to actually explain it to you at the end as well. Okay? So, and that's what I said. And here's another thing. I actually started a little bit of a discussion on the Twitter page for the Medical Education Without Borders about the antiphospholipid syndrome. I did not get a lot of interaction from you guys. So if we want to make this into a much more beneficial site and we start a discussion, I need to see more participation. Okay? So there are some questions that I asked, but we didn't get the answers to it. So it's either that you guys didn't know or the question was too easy, which I don't think it was, right? Because we were talking about antiphospholipid syndrome and all that. So I do urge you to participate, because you know what? If it's something that you get wrong, that's the whole purpose of it. And if you get it right, guess what happens? You've just helped other people learn. All right, that's the whole purpose of a discussion. And you know what? Once every single time I give a lecture, whether it's to medical students, residents, all that sort of stuff, every single time, I learn something from somebody. Because you know what? Knowledge is endless. And I sit there and somebody will say something and I'll go, oh, wow. Oh, that is interesting. Okay. So I'm going to go through it. The question was about anastomosis and cervical lengths 4. And the question that I put on the Twitter account was about antiphospholipid syndrome. All right. So this was you guys before the lecture, right? And now this is what you guys look like, right? Is that right? All right. Now, before I move on, anybody has any questions about alloimmunization? Anybody has any questions about alloimmunization? Any questions? Okay, sounds good. Now, I also urge you to follow Medical Education Without Borders on Twitter. Feel free to follow me as well on Twitter. I always enjoy what you call it. I always enjoy a good discussion. If you don't want, if you want me to answer, and I've had multiple emails, and as far as I know, I have answered every email question that I got. And if I don't answer it, right, it means that I either did not receive your email or it went to junk and I didn't pay attention to it. Okay. So there it is. There's my Twitter, and there's my email, and there's Medical Education Without Borders email. Now, my next lecture is going to be on the 13th of May, right? It's going to be these times, depending where you are in the world. Okay. Week D has gone away now. You treat it as if it's Rh negative. All right. And I will repeat the amount of transfusion once I talk about the twins and all that sort of stuff. All right. So let's talk about, do you want to say something, Haytham?
Yeah, there are a few questions I can see here in the chat.
Okay.
There's one of them that said, yeah, what are the high-risk antibodies other than KEL?
So what I can tell you is there's plenty of antibodies, and what happens is there's actually a table of about 3 or 4 pages that you just go back to and you see if your antibody is high risk or low risk. And that's what most of us will do.
Okay, there's another question here that says,
here, some people are asking.
do we give anti-D after ACV even though she was given anti-D at 28 weeks?
So it depends. Most people will say that if a procedure happens again within 3 weeks of your initial, you shouldn't. And some people will also tell you that your anti-D covers you for about 12 weeks. So it's a controversial topic. I guess it depends on how much manipulation you do, and do you really think that you caused excessive fetal cells to go into the circulation? Okay, am I missing any other questions?
Yes, another question is there's a question by Honor X. What about grandmother theory?
What can he explain what he means by grandmother theory?
So can you please explain what you mean by grandmother theory? Because I'm just reading the question. It was written by someone called Honor X. Can you explain your question, please?
The half-life of anti-D while we wait is 23 days. which is why 3 weeks is what most people will say it goes by half. So some people advocate for repeating the dose 3 weeks from, so for example, right? If you have somebody who you gave it 28 weeks, the Rhogam, and then a car accident happens 4 weeks afterwards, some people will repeat because you've gone below the half-life. If it happens within a week, some people will say no. The other thing also is,
there was another question in regards to calculation of the Rhogam dose. Someone wants a repeated explanation of the Rhogam dose.
Okay, so what we'll do is we'll go back to the slide. All right, so, and like I said, if I've missed any of your questions, just feel free to email me and I will email you back the response. All right, so don't worry. And then, like I said, if it's something that I feel I've gotten multiple questions for, I will, what you call it, I will get back to it on a slide as well. Okay, so when we look here, yes, okay, so the amount of blood that crosses into the circulation causes the more blood that you get, the more you get a response, okay? The more that you cross into the circulation, the more you get a response. So the KB stain calculates how much blood has crossed into the circulation. And there are multiple ways that the blood can cross. Number one, it can happen as 30 mLs of whole blood or 15, there's multiple ways of calculating it. You can also calculate it as whole blood, or you can calculate it as fetal red blood cells. And if it's whole blood, 30 mLs, then 1 ampule of Rhogam only covers you for what you call it, 30 mLs of blood and 15 mLs of packed RBCs. So if you do your calculations and the KB stain comes back and tells you that the percentage of blood that has crossed is, let's say, 3%, then what you do is you do 3 times 50, which means that you have 150 mLs of blood that has crossed. You divide that by 30, that gives you how much? 5. That means you need to give 5 ampules of Rhogam and so forth. Is that now making sense? Yeah, so I'm not very familiar with the grandmother theory. What I can do is if you can email me, I will search it for you. Okay, I'm not very familiar with it.
Okay, there's another question. A late booker, let's say 32 weeks her, she's an Rh negative. Can I still give her anti-D?
Yes, absolutely. Oh, absolutely, absolutely, no questions.
Okay, there's a question by Dr. Muhammad. He's writing it down.
Okay.
And there's also Noura. How will give 5 ampules every 300 mics?
You can give 5 ampules, or if you're giving a whole lot of ampules, your pharmacy can actually help give it IV.
There's another question about...
I understand the question of the grandmother theory. I don't know how true it is. I don't know how true it is. Okay, is there another question, Haytham?
There's another question about the half-life of anti-D.
Yeah, we said it's about 23 days.
Okay. So are there any other questions, guys? Yes, Majd.
So the question, there's a good question there. Do you test the antibody titer every 4 weeks or every 2 weeks? First of all, it depends how close we are to the critical titer. And it also depends on how many tests have I done with the titer being stable. So initially, if the titer is early on, most people will do every 2 weeks. And if it's stable for a couple of weeks, then they can space it to every 4.
Okay, there's a question about by Dr. Muhammad. What are the best outcome for the twin-to-twin transfusion syndrome one, artery to artery, two, vein
Yeah,
to vein, or
and that's the slide that I said I got a lot of questions. I'm going to talk to it as soon as I finish. I've got a slide for it.
okay. Majd is asking, so KB testing is a must after delivery for all Rh negative mothers, right?
No, not according to ACOG. It says consider it in times where you actually feel that there is excessive maternal fetal hemorrhage. However, there are some people that advocate for it, but the ACOG does not mandate it at this point in time, and it says only do it if you feel that there was excessive hemorrhage.
Okay, there is another question by Dr. Suhad. Lily and Queen's curve, is it applicable and important of MCA or MCA is enough?
No, MCA is more than enough. And you only do the Lily and the Queenan curves in the event where you don't have access to MCA Dopplers. An MCA Doppler is very sufficient. Okay, there are some people that say the only exception to that is after 34 weeks if you wanted to confirm the anemia, because your MCAs are not as reliable. But in general, you know, it has been a very, 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 very long time that I've seen anybody that has done, you know, an amniocentesis to get bilirubin.
Okay, another question by Dr. Noura. When given anti-D at 28 weeks approximately, when to check antibody before giving it means before that? I really don't. Yeah.
So what most people do, you know, you're not going to bring the patient back and forth. Most people still, even though you're supposed to check it, will draw the blood, send it to the blood bank, and then give the Rhogam. But if you wanted to check, you can bring the patient 1 or 2 days before and check it and then give the Rhogam. But for convenience and for the patient to stick to coming, they're not going to come 2 times. So what we do in our office is we draw the blood for type and screen and then give them the Rhogam.
Another question is, how many days do I have to give anti-D after bleeding or trauma?
72 hours. But the closer that you get, but the closer you give it, the more likely it's going to be effective, right? Because you want to fool that immune system, but you've got 72 hours. So let's say if somebody comes in and she was involved in a car accident yesterday, you can still give it. But the ideal is as soon as she comes in after the car accident, if she's Rh negative, you're supposed to give it.
Very good. So are there any further questions, guys?
So yes, there is. The reasoning is most people think that the maximum that the Rhogam lasts is about 12 weeks, right? Most people. So if you calculate 28 weeks to 40 is how long the Rhogam will last you, right? And the likelihood of fetal cells crossing into the maternal circulation increases as the gestational age goes up. Like I said, if I've missed any of your questions, and those of you that had the grandfather theory or the grandmother theory, please email me because I'm going to search that as well. Okay, you know, like I said, I learn something every time I give a lecture.
Okay.
All right. So let me talk about the cervical length and the twins, and then the shunting. All right. Those of you that like I said, we're only now talking about stuff that we talked about in the past. So here we go. So first of all, what is the role of cervical length screening in twin pregnancies? What is the role of cervical length screening in twin pregnancies? And the role is controversial, right? Because why screen for something that you're not going to intervene about? So remember what we said? We said that initially that you shouldn't put cerclages for twins, and pessaries were not helpful, vaginal progesterone is not helpful. Then the question is, well, why do I screen for them? So the counter thought of that is there are people that will screen for them, and if they're short, then they know that these type of twins are at a much higher risk of delivering early. They'll have a lower threshold for admission, starting steroids, giving them tocolytics. And you know, even though the American College's recommendations is not to do cerclages, there is still a very, very high number of MFMs in the country that will still put cerclages in with good effect. So those people will definitely be screening for cervical lengths. Okay, so the role of cervical length screening is definitely controversial, but most people that I know and most of the country, what they do is they will do at least one cervical length screening with their anatomic survey. That way they will assess the risk and the degree of risk of this patient going into preterm labor. And then there's also, if you look at the twin data, there is a subset of data that says if your cervical length is less than 1 centimeter, then putting a cerclage is helpful even in twins. Okay. So like I said, even the studies that go out, what I'm doing right now is giving you what is in the latest ACOG practice bulletin. I'm aware of the studies that are coming out, but my job, unless ACOG endorses it or tells you it's standard of care, I can't give it in a lecture, right? Sounds good. So Andra, your points are very valid. There are people that will give vaginal progesterone at less than 2.5 millimeters, pessary, all that sort of stuff. But again, if you go to the practice bulletin from ACOG that is right now at this point in time published, it does not recommend any of them. All right. So what I did for you guys is there is an SMFM clinical guideline about twin-to-twin transfusion syndrome. And I specifically looked at the vascular anastomosis for you guys, and I have put them there. Okay, so there are 3 types of vascular anastomoses. There's venous, arterial-arterial, and arterio-venous. Now, the arterial-arterial and venous-venous are superficial, and they're bidirectional. The AV anastomosis is usually not a problem, but it can be unidirectional. That means the AV anastomosis goes from more to one baby. When that happens, usually the AA and VV anastomoses balance it to prevent twin-to-twin transfusion from happening. If they're unable to balance it, then twin-to-twin transfusion will happen. It is more likely to happen in placentas that have more venous to venous anastomosis. So the problem is usually the AV anastomosis, but the placentas that have more venous anastomoses are more prone to getting twin-to-twin transfusion. Okay, so that slide is good. And I actually do urge you, and that's why I put this here. This is a beautiful, beautiful article written by Dr. Simpson of Columbia. Beautiful article. So if you just Google SMFM twin-to-twin transfusion, it is a beautiful article that takes the most complex questions about twin-to-twin transfusion and answers them one by one. All right? All right, so I think we are right now at the end of the lecture. Please feel free to email me if you guys have any questions, and I really hope that you benefited from today's lecture. The answer to what? Okay. All right.
Okay, guys. I think we have no questions further. I just shared with you the Twitter account. So please follow the Twitter account, and you're going to find the link for the upcoming lecture on it. Please register from now, and you're going to receive the email with the link of how to enter. This is again the link for Twitter account. Here you go. So you can click on that, enter into Twitter, enter the account. You're going to find the next lecture for Saturday. Saturday, Dr. Wajih Al-Ali is going to be presenting about fetal hydrops, an ultrasonic approach, and I'm sure that you're going to benefit a lot of this lecture. So please, let's see you there.
All right, take care, guys.
Thank you very much, Jamil, Dr. Jamil, and I hope to see you soon, inshallah. There's a question, Dr. Jamil. What's the best outcome for twin-to-twin transfusion syndrome? Can you see that by Dr. Muhammad?
Yes. So first of all, okay, let's go back because I saw multiple questions from you. Number one, it is more likely to happen when you have more venous to venous anastomosis because they're unable to overcome the AV anastomosis, right? The best outcome is definitely going to be so there's a few things that determine outcomes. Number one, it determines how early you actually do your ablation and what damage has already happened. Do you have severe IUGR, abnormalities of the Dopplers? Do you already have hydrops that has developed? Okay, so those are usually what play the outcome. Oh, Send me the question. Send me the question as it came in the exam, and I'll answer it for you. Okay, wait a second. What is the best outcome? So AA, arterial. That's the best outcome. Okay? It's artery to artery. Okay, that's the best outcome. All right, take care.
Okay then. Thank you very much, guys, and see you soon.